Hello, my name is Helen, and I'm a child psychiatrist and epidemiologist in the Department of Psychiatry at Duke University Medical Center. And my area of research is preschool mental health. The work I'm going to be presenting today is from a program of research I've been doing with my colleague Adrian Angold, who is a co-author of this talk. Today I'm going to focus on pediatric anxiety disorders. First, let me give you an overview of what I'm going to present. I'm going to be addressing a number of questions that are related to the presentation of anxiety symptoms and disorders in young children. I'm going to be focusing on children who are 2 to 5 years old, and I'm going to focus on what I call, which are the most common anxiety disorders. So that includes separation anxiety disorder, social phobia, specific phobia, and generalized anxiety disorder. I'm not going to be addressing PTSD and obsessive-compulsive disorder in this talk. So here are the 4 questions that I'm going to address during this talk today. The first thing is I'm going to talk about how we define the boundaries between normal anxiety in young children and clinically significant anxiety and disorders. After that, I'm going to talk about the question about whether we can actually identify DSM-4 anxiety disorders in preschool kids. Third, I'm going to talk about how these anxiety symptoms and disorders in young children are similar to and in other ways different from the disorders that we see in school-age children and adolescents. Then, lastly, I'm going to take a little bit of a turn away and give you a brief overview of assessments in clinical settings of preschoolers with anxiety disorders, and a quick overview about treatment options. So I want to start off by sort of giving you a broader view of infant mental health, sort of where we are right now. And the somewhat discouraging thing is, in many ways, the field of infant preschool mental health is about 30 years, maybe 25 years, behind the knowledge that we have about psychiatric disorders in older kids. Now, an exception, and a very good one, that gives us a roadmap for the future is autism, which has made great strides both in understanding diagnosis of autism and maybe getting closer to understanding what the causes of autism are. And we also have made some progress in ADHD. But overall, there's some very big gaps in our knowledge. Now, the good news is that recently we've been able to develop some measures to assess these symptoms and disorders in young children and do the kind of studies that are going to enable us to answer some of these questions. We certainly are not planning to have it take 30 years for us to catch up, but really hope that we're going to be able to leapfrog by building research and a clinical research programs on what's been done with older kids. Now, there have been 2 common arguments made against the idea that we can diagnose psychiatric disorders in young children. And the first one is that little children are changing so rapidly across multiple domains, so across physical, neural domains, behaviorally, emotionally, cognitively, that the changes are happening so rapidly that there's no way that we're going to be able to measure symptoms or that they will be valid or stable enough. The other argument, and this is a concern about overdiagnosis and labeling, is that we're going to diagnose very young children with disorders when they're just showing normal developmental behavior for their age. Now, I do want to remind people who are listening that we've heard this argument before, and that was in the 1970s when people were starting to do research in childhood depression. And arguments were made that we couldn't diagnose it in children, that included adolescents, that we wouldn't be able to define it, that it would look very different than depression at other ages. And as everyone knows, that turned out not to be true. And the ability to make these diagnoses and understand how common depression is in adolescents and younger children has really enabled us to develop treatments and identify kids who are suffering. Today I'm going to talk about a study that we've been doing at Duke for the last 8 years. And this is a study of psychiatric disorders in preschool kids. I'm not going to go into the details of the study, but just to say that we screened in a pediatric primary care clinic 1,200 families of preschool kids and then identified 307 children and their families, and now we've been following them for 6 years. We are currently in the process of doing an 8-year follow-up of that sample. So we have data then on these children starting from age 2 to 5 going up into the beginning of adolescence. We used a psychiatric interview in the first part of the study called the Preschool Age Psychiatric Assessment, also known as the PAPA, which I am the lead author on. And this is the first interviewer-based structured, comprehensive psychiatric interview for assessing the full range of psychiatric symptoms and disorders in children 2 to 5 years old. It also assesses family structure, family functioning, risk factors, so provides an opportunity to look at environmental risk. The key point here, and this was the first question we answered in our study, is the PAPA is just as reliable as any structured interview for children, for adolescents, or adults. Now, that doesn't mean we know everything about psychiatric disorders in preschoolers, but it does mean we can start the work to understand how these disorders present, how common they are, and how we should treat them. So first, we're going to ask this question. How do we define the boundaries between normal variation and clinically significant anxiety in young children? Now, preschool anxiety has been looked at mostly as either a normative phase of development, and so we know that commonly very young children will have stranger anxiety or will have some kind of separation anxiety where they don't want to be away from their mother. Then anxiety has also been looked at as a temperament style, and there's been a lot of work in the area of behavioral inhibition, and I'll give some details about that. Now, in the last few decades, people have thought about clinically significant anxiety, but it's been more symptoms here and there. Very few people have looked at anxiety disorders as they are defined at other ages. Now, here is a graph of data from our study looking at separation distress, and I'm using these data to address the question of whether it's just normal for preschoolers to get distressed when they're separated from their primary caregiver. And what you see here is that it's much more common for 2-year-olds, which we would expect. So about a quarter of 2-year-olds get significantly distressed and upset when they leave their caregiver. And it becomes a lot less common by the time kids reach 5. Now, on this graph, the areas that are in red are children who experience separation distress but are also impaired in their functioning in some way. And what you'll see is that the rate of impairment is about the same going across. It's about 8 to 10% of preschoolers who have separation distress are also impaired. Either they can't go to school or the parents can never leave them with a babysitter. But you see also that for those kids, those 5-year-olds who are still experiencing separation distress, about 3/4 of them are impaired, while for the 2-year-olds, only 1/3 are. So again, it is more common for very young children to have separation distress. Some 2-year-olds have it at the level of impairment, but if that persists as the child heads towards kindergarten, it's much more likely that it's going to be causing that child some kind of problem in functioning. Now, there's been a big debate in the research community about whether some of the things that our group has studied is really psychiatric disorder or whether we're just measuring temperaments from the early childhood personality. And certainly there's been a very important body of work led by Jerome Kagan on behavioral inhibition, which has identified about 15% of young children starting in infancy who have a style of interacting with new people or with new things in a way that is very inhibited. They get very scared, they withdraw from it. And there's been a lot of work showing that these children are at much greater risk of having anxiety disorders and depression later in life, and that they have moms and dads who have anxiety or depression. Now, certainly I'm not suggesting that all children who are behaviorally inhibited have a psychiatric disorder, but I will challenge everyone who's listening to sort of put in the back of their mind as we go through this talk whether or not some subset of these behaviorally inhibited children actually have what we would call in psychiatry an anxiety disorder.